Okay, guys, so we're just making a little video to go over some of the muddy points or points of confusion from today's past session. So bear with me, but I'm going to try and talk you through the concepts around spinal cord injuries, and hopefully this makes sense because I don't have you guys here with me to give me an agree or a happy face and let me know if you're following. So first, what we'll talk about is just this image that you guys should be really familiar with by now. We have looked at it a few times. So one of the concepts that we talked about today that seems to be a little bit unclear for you guys is the differences between the spinal nerve, which is here, and the peripheral nerves, which I'm going to highlight in purple, which are out here. So we've got two of those coming off. So what I'd like to draw your attention to with this image is we're really just looking at one spinal segment. So we're going to call this spinal segment C8. Excuse my horrendous writing. So if we've got C8 here, we can see the C8 spinal nerve carrying both sensory and motor information from the dorsal root and the ventral root. So those combine in that spinal nerve, and then they break off into multiple peripheral nerves. So one spinal nerve can give that sensory and motor information into multiple peripheral nerves. So we're going to use the ulnar nerve as an example. I'm going to use the text function so that you can actually see the writing. So if we've got the ulnar nerve over here, so our ulnar nerve is a peripheral nerve, and that nerve is getting some motor information from our C8, and it's also getting sensory information from C8. Now, if we extend that and we show that up here, and I'm just going to star that. So this nerve up here is another peripheral nerve. Let's just say that that's the radial nerve. Now, this is not going to be anatomically correct. So if we just pretend that that is the radial nerve, you can see that again, you have got sensory and motor information being fed into that radial nerve from that same C8 spinal nerve. So your spinal nerves can give off sensory and motor input into multiple peripheral nerves. Now we're going to look at the flip side of that, which is that peripheral nerves can also be fed by multiple spinal nerves. So what I'm going to do is I'm going to draw a super dodgy T1 down here. So if we just pretend that we have a duplicate of this same image, we've got our T1 here, and I'm going to draw in our sensory. So if we've got our sensory coming along, now let's just say that that's our spinal nerve at T1, and then it will come up through here. And then we'll have some motor coming from T1 as well. There's our spinal nerve, and then that is also going to come up and join this ulnar peripheral nerve. So I hope that that makes sense, that our ulnar nerve here, we can see that we have input, the sensory and motor information in the ulnar nerve, coming from both the C8 spinal nerve and the T1 spinal nerve. So we've got spinal nerves that can feed into multiple peripheral nerves, and our peripheral nerves can be fed by multiple spinal nerves. So our ulnar nerve has got innervation from both the C8 and the T1 spinal nerves. I hope that that makes sense. I'm going to try and screenshot this for you so that you can come back and review this. This is a really important concept for you to understand, and you will be looking at this both later in this course and in other courses as you continue with your degree. So, on that note, if that sits okay, we will move on to the concept of the cords and the tracts. So if we're now looking, I'm going to use yellow, and we're now looking at the spinal cord. So we're now in the central nervous system, and And essentially what we're doing with these two images, I'll just highlight that for you, is we're looking at a cross section or a horizontal slice through the spinal cord itself. Now, for some reason, the person who created this image, which was not myself, didn't think that the lateral corticospinal tract was important, so they didn't put it in there. So I'm just going to color it in green for you. So these two triangle shapes here are our lateral corticospinal tract. So they're carrying our motor information. So this horizontal slice through the spinal cord goes in between each and every one of your vertebrae, and you've got the vertical highway of information for each of those tracks coming up and down. So if you then draw your attention over to the little man on the side, I'm going to highlight him in orange. So our little orange man over here, you can see that you've got a few different tracks on there. You can see that they're going straight up and down. So sometimes it helps for you to think of the peripheral nervous system as the nerves that are going from just outside of the spinal cord out to the periphery. And if you think about the upper limb, they're kind of going more horizontal or diagonal, whereas your vertical tracks, so your DCML in your central nervous system spinal cord, they're going straight up and down. So if we've hit into that vertical tract, we're not only going to impact the level of injury, but we're also going to impact everything below it. So I'm going to use a little black pen. I'm just going to put a star on the spinal nerve. So if we had an injury here, please ignore my dodgy drawing skills. So if we had an injury to the spinal nerve, and let's say that this is the right C8, if we have an injury there, we're going to see deficits just in the distribution of that one C8 nerve on the one side. So it's going to be a peripheral nerve injury, and the deficits and symptoms of that we will see will only be in the C8 dermatome, and it will be unilateral. You could also say it will be ipsilateral because the symptoms will appear on the same side as the lesion. So I hope that that makes sense for you guys. And the further that you go down, so if we went down to say the ulnar nerve and say that we had an injury of our ulnar nerve, I'm just going to color both of those. If we've injured the ulnar nerve, and we're going to then see the distribution of symptoms and deficits only in the ulnar nerve distribution and only on the side of the injury. So that would be an ipsilateral or a unilateral injury in the peripheral nervous system. I hope that makes sense for you guys. So we'll move on to the cords. So if we have now got an injury in our cord, so if we've got anything in this yellow circle, then we're going to be looking at a vertical tract. If it's impacted a vertical tract, you're going to see those symptoms and deficits in everything below it. So with our spinal nerve injury or our peripheral nerve injury, it was in that distribution of the nerve only. So say it was the C8 dermatome only, your T1, your all the way down to your sacral nerves, everything under it would be absolutely fine. There would be no symptoms below that level of injury. It would just be the C8 dermatome. Whereas if we're looking at a spinal cord injury, then you're going to see those symptoms in that level of injury, and everything below it will be affected. So if I draw a little star over here on our little man, if we have a lesion at that level, then we're going to be cutting off the motor supply going this way. So it's going to stop there, and it's not going to be able to get down to the leg here because we've interrupted it. And likewise, information that's coming up is not going to get past that level of lesion, and it won't be received by the brain. I hope that makes sense to you guys. If you've interrupted that vertical highway, creates a traffic jam, and that information cannot get through. So if we put all of that together and we come down to the diagrams at the bottom now, I'll just put a little around them. Okay, so if we're looking at these two images at the bottom here now, and we can see that there's a star there showing us a lesion. Okay, I haven't gone into exact what level this is. This is just for a visual representation of what we're talking about. So we can see that this is in the cord, and we can see with this star, we can see that it's impacted the DCML over here. So we're going to have interruption to our DCML tract. We can see this part of the star has interrupted the lateral corticospinal tract. So we're going to have some motor impacts. And we can see that this part of the star is actually hitting the spinothalamic tract there in the red as well. So this spinal cord injury, which is still only on one side of the spinal cord, has impacted 3 separate tracts. So if we now look at our little man and we see that we've got cut off here, and let's just say that there's a complete loss in that side, what we're going to see is now our motor information cannot get through. So if we follow the motor tract, we're going this way, it's going to stop here, and we're not going to get any motor information coming down this leg. So that's going to be an ipsilateral loss of motor function. So ipsilateral, because it's the deficits and symptoms are on the same side as the lesion. And the reason for that is because that lesion is occurring below the point of decussation. So if you have a lesion that occurs after your tract has already crossed the midline, then your symptoms are going to be on the same side. Whereas if we had a lesion that occurred before our tract had crossed the midline, we would see contralateral. We're going to look at that in a moment. So let's just sit with motor on this diagram. So you can see that's now not getting through. And we can see our little red arrow continues down the same leg because we've already crossed the midline. So we now have ipsilateral loss of motor function. So if we now have a look at our DCML, so I'm going to draw that in blue. So you can see that our DCML information is trying to come from the foot up to the brain, but once it hits this lesion, it can't get through. So because it's not getting through, our brain's not receiving that sensory information. And again, the lesion has occurred below the point that we crossed the midline. So our symptoms and deficits are going to be on the same side as the lesion. So therefore, we're going to have an ipsilateral loss of sensation below the level of lesion. I hope that makes sense. If it doesn't, I guess you're just going to have to listen to this again, or you can pop in the comments some questions and we can have a discussion about it. If we now look at the spinothalamic tract, which I'm going to do in purple, and I will just update that on the legend. So spinothalamic in purple. So we can see that the spinothalamic tract actually decussates at the point of entry. So as soon as your spinothalamic comes into the spinal cord, it crosses over immediately. So where our lesion is, it's actually above the point of decussation. So we've got spinothalamic information trying to come up the leg and through the lesion this way. So what we will actually see here is that information from the opposite side is not getting through to them. So that would be a contralateral loss of sensation. Contralateral because the deficit and symptoms are occurring on the opposite side to our lesion. So hopefully that makes sense. You guys are probably going to need to have a look at this. I will upload a copy of this slide separately and practice drawing these diagrams. Before exams, I literally sit on my couch with a whiteboard and I draw diagrams and tables over and over and over again until I can see that information in my head, or at least take that information and draw it or scribble it on exam paper. So my exams always look funny. They've always got lots of weird little notes on them, but that is one of the strategies that I've found works for me, and hopefully it can work for you too. So I'm just going to pop over to the next slide. And this slide's just looking at the different questions that you need to ask yourself when you're looking at a spinal cord injury. So obviously, the first thing that we're going to be asking ourselves is, where exactly is the lesion? And is it a complete or an incomplete? So the name of your spinal cord injury should tell you that, because if you recall, and I'll pop back up to it while we're here. If we recall this little flow chart, the name of the spinal cord injury, it might be a C5 incomplete spinal cord injury. So that's going to tell you the level of injury first. So where in the spinal cord are we looking? And have we got a complete loss or an incomplete loss underneath? So those are the first things that you're going to ask yourself when you're looking at these lesions in case studies, is realistically where you're going to be seeing them. So next you need to ask yourself if it's affecting the peripheral nervous system, the central nervous system, or both. So if we have a lesion, I'm going to draw in purple for the peripheral nervous system. So if a lesion out here on our peripheral nerve, here on our spinal nerve, or here on our ventral root, they're all going to be peripheral nervous system injuries. So with a peripheral nervous system injury, you're most likely going to see that be unilateral, because it's not in that vertical cord or those tracts. So when you're thinking or you're seeing these kind of injuries, you're thinking about, has it affected motor, sensory, or both? Because that's what's being carried through those spinal cords, because the tracts have all converged at that point and they're all sending the information out or back into the spinal cord in this area. Hope that makes sense. So peripheral nervous system, that's going to be unilateral, and you're going to be thinking about whether motor and sensory and both have been affected. If we pop down to our central nervous system, which I'm going to do in orange, so I'll just put a little star next to that. So our central nervous system, that's occurring in here, and we're just going to outline our little star in orange. Gosh, that outline went terribly. If we're in the central nervous system, so this is going to be a spinal cord injury, we need to think about what tracts have been impacted by that lesion. Where is it sitting? What's it touching? And that's what's going to tell you the next part of what your symptoms are going to be. So if we say, let's have a look at a different one. So if I've got a little black star, and that's terribly drawn, but if that little black star is only touching that red spinothalamic tract, then the only things we're going to be losing are going to be temperature, pain, and coarse touch. So they're the only sensations that will be affected by that kind of lesion. And again, if it's only on one side, then you're not going to have a bilateral presentation. If you had a complete spinal cord injury where that whole cord is severed, that's when you're going to have bilateral symptoms. I hope that makes sense. So if I draw in our little man, we only have one side, so lesion that's only in one half of the spinal cord, then you're going to have just one side for each of those sensations affected. But if we have the whole cord cut, so that's a complete spinal cord injury. So that's completely severed, nothing's getting below it on either side. That's when you're going to have bilateral symptoms. The next time that you can experience bilateral symptoms is if we have more than one tract that's been affected, even if it's only in one half of the spinal cord. So we briefly touched on that in our previous diagram. We're going to just briefly go over that one more time. So we can see our orange star there, that's touching the DCML tract, which we'll draw in blue. So our DCML tract is here. We can see that the star's definitely touching those. So we know that our DCML is going to be affected. And we know that because we're in the central nervous system, everything below it will be affected too. We've got the same thing happening with our spinothalamic. So you can see this section of the star here and here has impacted our spinothalamic tract. And then we've also got our lateral corticospinal tract sitting here, which is now also being affected. So back to our little man, if we're having a look at the spinothalamic, so again, I'll highlight that for you because it's a bit hard to see in this diagram. So on this diagram, we've got spinothalamic is shown in red. So I'll follow suit with that. Excuse my scrappy drawing skills. Okay, so we've got spinothalamic in red. So if we follow the spinothalamic tract, we can see that that one crosses at the point of entry in the spinal cord. So in this little man, the spinothalamic tract hasn't crossed the midline yet at the point of injury. So we've got information coming from the opposite side of the lesion trying to get up to the brain. So our symptoms for this lesion in the spinothalamic distribution is going to be contralateral. So we'll see a contralateral loss of temperature, pain, and coarse touch because it can no longer get up to the brain. If we then have a look at our DCML in blue, we can see our DCML information is trying to go up. That's a terrible line, excuse me. It's trying to go up the leg. It has occurred after the DCML tract has already crossed the midline. So it's everything below on the same side. If we then go to our corticospinal, so in my little diagram, I did him in green. So we'll just highlight that, corticospinal in green. So this is our motor information. Now that's going to be trying to come down from the brain and go down to the leg. And it's going to get stuck at that lesion and it's not going to make it to the foot. And that's going to be on the same side because the injury has occurred after that tract has already crossed the midline. So everything below it will be affected on the same side. So for this one, we've got ipsilateral loss of voluntary motor control. So I hope that that makes sense for you guys. Hopefully I've explained that well enough. So you're always going to need to know where these tracks cross the midline because you might not always have these diagrams to help you. So practice drawing them and practice your summary tables as well so that you know what each of these tracks carries and where it crosses the midline. The cross section, so that's this over here, this cross-sectional information. I don't think you will need to know that for your mid-try exam. Don't quote me on this. I think you'll explore this in a little bit more detail later in the course. So as far as priorities go, just understand where those tracks are running, what they're carrying, and where they cross the midline. So don't worry too much about the cross section. That's probably a little bit deeper than you need to know right now. Hopefully that makes sense for you guys. If it doesn't, please don't hesitate to reach out. And hopefully that clears up those muddy points for you. Happy studying.